Okay, this is video number 4 for the circulatory system, and this is the slide we left off on. Again, we were talking about DVTs and the risks for them. Signs and symptoms: calf or groin pain, sudden or onset of unilateral swelling, and you might have warmth or heat where that edema is. One thing you want to make sure with a DVT patient that you're not elevating their legs, because you don't want to give that, or massaging them. You don't want to release that clot. We want to make sure that it stays where it is. Here is a picture, some sonography, and you can see right here, there's a clot right there. That's kind of hard to see, but again, if you want to YouTube DVT or venous studies, that would be interesting. When someone goes for them, they're just sonograms of the legs. There's no pre-op or post-op care. You just have to tell the patient what they're doing. And basically they start up here with the femoral arteries and veins, and they work their way down, looking for any kind of clot, or you can see here where the blood's just not flowing anymore because there's a clot right there. So that's what they're looking for. Then they do a blood test called a D-dimer, and this measures the fibrin. It actually measures the degradation of fibrin, and it's present in the blood whenever there is any kind of lysis of the fibrinogen cells. The D-dimer will elevate if they're, especially if there's a PE, which is a pulmonary embolism, and that basically is a deep vein clot, deep vein thrombosis that has traveled its way through to the lung. So we certainly want to prevent that. By the way, D-dimer would be a really good test if you haven't already. It's a good lab to add to your lists of labs, because you will see that quite often. So how are we going to treat deep vein thrombosis? The first baseline drug is heparin, and sometimes they give straight up heparin, either IV or subcutaneously. You guys will probably start giving that in the summer or the fall, depending on where your clinical rotations are. Quite often, if we don't see heparin, either IV or subQ, we're seeing a lot of Lovenox in the clinical setting. Not too long ago, and I'm talking within the last couple of years, if you came to the hospital with a DVT, you were immediately hospitalized, sometimes for, 3, 5, 7 days, until your combination of heparin or Lovenox and Coumadin got to where your PT and INR was therapeutic. And therapeutic is usually like 3 to 5. For Coumadin, the PT and INR. PT would be like 3 to 5, and INR is the international normalizing ratio. And we can talk more about those labs. But so you want to know the labs for PT and INR, and then PTT, which is actually measuring the anticoagulant level when the drug heparin is being used. So what happens when someone comes in with a DVT? They are, first of all, they do a D-dimer and they do an ultrasound to make sure there is a DVT. So once that's been established, then they start the patient on either heparin or Lovenox. Now, like I was saying, back in the day, not too long ago, a couple of years, you were hospitalized, started on heparin right away, started on Coumadin right away, but Coumadin doesn't really start to work in your body till 2 to 3 days. So the heparin keeps you safe. These drugs do not absorb the clot. They do not dissolve the clot. What they do is they make your blood slippery enough to go around the clot. That's the easiest way I can describe it. So in order to keep your body safe so that clot won't move, heparin is started. Now, Lovenox is actually heparin, but it's low molecular weight. So how it's absorbed by the body is different. Now, they will send a healthy person. So if you have a DVT because you broke your leg, or something like that, if you don't have a ton of comorbidities, they will send you home. They'll teach you how to give yourself Lovenox, and they'll send you home for outpatient care that day. You'll go to the ER and you won't be admitted. That is a very, very new thing. But the heparin or Lovenox is started. Coumadin is also started. And then they're watching your PTT, your PT, and INR levels. When your PT and INR levels become therapeutic, in other words, the Coumadin is doing its job to anticoagulate your blood so that it can pass over the clot, then you can stop taking the Lovenox or the heparin. These drugs are very short term. Coumadin's long term, like probably at least a year. During that year, your body will absorb the clot. Like I said, it will not, these medications do not blow up the clot or dissolve it. They just let the blood work around it. Once you're on Coumadin, you have to be very careful, and patient education has to be done, because the antidote for Coumadin is vitamin K. Vitamin K is found in rich, dark, leafy green vegetables, spinach, kale, though that line of broccoli vegetation. So if the patient eats a lot of those vegetables, then the Coumadin has to be adjusted accordingly. Again, back in the day, they would tell patients don't eat leafy green vegetables. Well, that's kind of the dumbest thing you can tell a cardiac patient, because the best thing for them is dark leafy green vegetables. So it's better for the patient to give them more Coumadin to counteract the vitamin K. However, if somebody's PT and INR gets so high that they're dangerous for a bleed, then we will give them vitamin K to coagulate the blood. They also use integralin, Activase. These again are agents that work in the blood to make it more slippery, more fluid, so it can go around any kind of clot that you have. You'll see integralin in patients who are awaiting bypass surgery. That's about the only time you really see that drug. Again, these drugs and these tests are good for you to keep in your library of things to know. All right, so what are we going to do for this patient? We're going to continually measure and monitor the affected extremity. We're not going to massage it. We're not going to elevate it. We're just going to keep it comfortable. We want to monitor for any kind of change in mental status, shortness of breath, or chest pain, because if that happens, and it will happen very quickly, that means the clot moved to the lung, and we really don't want that to happen. Patient will be on bed rest. Even if they're sent home, they're going to be sent home on bed rest. Again, don't massage it. Patients, the best thing we can do is prevent a DVT. So post-op patients will have TED stockings. They'll have sequential stockings, the compression devices that pump up and let go and pump up and let go. So even if the patient is immobile, that blood is still circulating. We're going to be monitoring lab values, platelet counts. We're going to educate them, and I'm telling you, this will be on your boards. We want to prevent any kind of bleeding, so they'll have an electric razor, not a regular razor. They'll use a soft toothbrush. Anything that could cause them to bleed, we want to stop. We want to keep their skin intact. And then we want to always check for signs of bleeding, which would be huge bruises, anything like that. Any patient who is on heparin will also have an order, heparin, Lovenox, or Coumadin, will also have an order for vitamin K. All right, next on our agenda of cardiac or circulatory diseases, let's talk about Raynaud's. I've seen a couple of cases of Raynaud's. It's kind of, in that nursing world where diseases are cool, Raynaud's is kind of cool. It's vasoconstriction that usually affects the hands. You see it in women, and their hands will just randomly get cold and turn blue. They'll have spasms. It's caused by spasms of the small arteries. So people who have Raynaud's, there's a couple of things that you want to do. You don't want their hands to get cold. So, You want to make sure they know in cold weather they should always wear gloves. They should have gloves or mittens with them, so when they start to have an attack, they can warm up their hands. You see it sometimes when people have autoimmune diseases like lupus or scleroderma, rheumatoid arthritis, but sometimes people just have it. Sometimes it can become very serious and cause problems. Other times it's very benign and they just have attacks of it that don't cause any issues. Here are some pictures of Raynaud's. You can see they blanch, so they're not getting any blood flow. This blood flow is there, but it's not oxygenated, so it's cyanosis. There's pain, blanching, reddening. Treatment really is keep the hands warm and do anything that avoids vasorestriction or constriction. So no smoking, no alcohol, no caffeine. Next one is Buerger's disease, and I've never seen a case of Buerger's disease, and looking at the pictures, I'm really glad that I haven't. It's more common in men than women, but more women that smoke, it's more common with them. According to the Mayo Clinic, any person who's ever been diagnosed with Buerger's disease is a smoker. So, what's that say for patient education? They question whether it's an autoimmune disorder or if it's just a horrible side effect from tobacco use. Obviously, it's a arterial sclerosing, so the arteries and veins, they lose their ability to pump down to the extremities. Starts with numbness. Eventually, they lose blood flow to their digits, and they can become ulcerated, they can become gangrene, and may need to be removed. Very sad and pretty preventable if you don't smoke. No cure. If you quit smoking, it'll help. And anything that will increase vasodilation, so calcium channel blockers, beta blockers, that kind of stuff can help. Always educate patients on why not to smoke. Maybe showing some pictures of Buerger's disease would be good. Always inspect, especially the lower extremities, but the upper extremities too. And then we want to reduce the complications of gangrene and ulcer. So if they start to have an ulcer, we want to treat it. We want to make sure they have good skin care, good foot care, similar to that of diabetes. And if it gets bad enough, again, they have to have amputation. Now we're going to talk about some of the big guns like heart failure. You will see heart failure, previously known as congestive heart failure. If I say heart failure or congestive heart failure or CHF, I use the words intertwined because until just very recently it was always congestive heart failure. But it's the inability of the ventricles to fill or pump enough blood to meet the body's oxygen demands. The ventricles just aren't performing how they're supposed to perform. And because of that, there's backup. You can have heart failure for a lot of reasons. Systolic heart failure, diastolic heart failure, left and right-sided heart failure, acute heart failure, and then there's chronic heart failure. And it's all the part of the heart that is affected. And in class, I'm going to give you a little diagram. When you're thinking of right-sided or left-sided heart failure, think of a car accident. And whenever there's a car accident, there's a backup of traffic. And that backup of traffic always happens behind the accident, not in front of it. So if you have right-sided heart failure, that's the blood coming from the vena cava in to the heart. So if the backup is on the right side of the heart, you're going to see jugular vein distension. You're going to see peripheral edema. At this point, I'm going to move on to the next slide or the next video. So this is the conclusion of video number 4. And hold on for video 5.